Thank you. Very good morning to all of you. I welcome all of you for the live webinar on blood clots and COVID-19. The resource person for this program is Dr. Saravanan Subramaniam, Scientist 1, Blood Research Institute, Milwaukee, USA. I welcome him on behalf of the department, on behalf of the institution. So, very warm welcome to you, sir.
Thank you.
With this, I request the coordinator of this program, Dr. Anand Vijay Kumar, to give a brief introduction about the speaker.
Thank you, Dr. Praveen. So I welcome all the department colleagues, HOD, principal of JSS College of Pharmacy for this live webinar on blood clots and COVID-19 by Dr. Saravanan Subramaniam. And a warm welcome to all the participants who are registered for this live webinar. So before going into the talk, let us give a small bio sketch of our speaker, Dr. Saravanan Subramaniam. So Saravanan Subramaniam has completed his B.Pharm at JSS College of, at Dr. MJ Medical University, and completed his pharmacology at Shastra University, and carried out his PhD in medicine at Justus Liebig University, Germany. So after completing his doctoral, he joined the Center of Thrombosis and Hemostasis, Johannesburg, Gutenberg University, Germany, and he has worked as a postdoctoral research fellow. And along with that, he has carried out a lot of research works in this field. And presently, he is working as the Scientist 1, Blood Research Institute, Versiti, Wisconsin Incorporation, USA. And to his credit, he has a lot of publications in his name in the area where he is going to give his talk. And he is also a member of various international bodies. To name a few, he was a member in Canadian Society of Atherosclerosis Research and member of International Society of Thrombosis and Hemostasis, and member of Royal Society of Chemistry, and member in American Heart Association, and a member in the British Society of Pharmacology. And in the September, he will be moving to Boston as a assistant professor in 2022. And he has received various national and international awards, and he has given a lot of lectures and talk in this field. And with this small introduction, I invite Dr. Saravanan Subramaniam to start his lecture.
Sir, please go ahead, sir. You can start your presentation now.
Shall I? Okay. Thank you very much. I will share my screen. So the host has to disable.
Sir, screen sharing activated.
Yeah, I could not share the screen actually.
Inge screen share activate பண்ணுங்க. எனக்கு blue right click அங்க click பண்ணுங்க. All panelists, okay.
Okay.
Sir, now you can try, sir. Yeah. Dr. Saravanan, you can try now.
Yeah, I'm trying.
Yeah, it's visible now.
Is it visible entire slide?
Yes, sir.
No, actually it goes from, now it is okay.
Excuse me.
Visible, sir.
Is it visible?
Yes, sir. Yes, sir.
Okay, so I only just made a screen only for the presentation. I kicked out the video part, the image part, so that I can cover the entire slide.
Yes.
Okay, is it fine if it is full screen? Then I can go ahead, right?
It looks good, sir.
Okay. Thank you very much for the brief introduction, and I would like to express my thanks to the Department of Pharmacology, Jesus College of Pharmacy, and also Dr. Vijay Anand for organizing this live webinar. Before I start my talk, I would like to highlight with regards to COVID-19 is that what we know now may change tomorrow. So there are so much of uncertainty is going on around the world, from epidemiology to disease pathology to treatment of strategies or treatment strategies. I'm holding a talk from the company developing DNA vaccines and drugs for COVID-19, and I have slides about this research technology, this information. So I'm having the Innovin and Mesoblast stocks. Severe acute respiratory coronavirus 2, or SARS, abbreviated as SARS-CoV-2, causes coronavirus disease 2019. It is a new case like in China. It most likely originated from animals, and it is a source between people. Since it is all over the world, in the countries, most of them had practice travelers. Although our scientific knowledge on COVID-19 is minimum, we still could reduce the spreading of the disease. So from other COVID-19 positive people, it spreads similar to flu through droplets created 19 positive people talks. If you look at the symptoms, it starts from 1-2 days after exposure. If you are exposed to COVID-19 positive people, if you feel that you are exposed, then quarantine yourself for 14 days. Some people have no symptom and most have mild symptoms. The common symptoms are fever, cough, sore throat, fatigue, difficult in breathing, and sudden loss of smell and taste, headache, muscle ache, and diarrhea. The symptoms are similar to spreading of COVID-19 or maintaining good personal hygiene, use hand sanitizer at frequent intervals, do not keep from the people who are sick at least 6 feet, and if you clearly know the people, a person is sick, have more than 10 feet away, and monitor your health irrespective of you exposed or you close contact with or without have COVID-19 or not, or even if it goes down to like a flatten the curve, it doesn't matter. It's minimum 6 months we have to wear mask, otherwise at any time will come up and or reappear as like what's happening in the US. So here is the website that this site provides live updates on COVID-19 cases worldwide. It looks like India is the next hotspot, and the cases are increasing exponentially. And you can go to the website and look at different country, and also when you click and when you go to different admins, there are 3 admins, and then when you click a country, it's admin 0, and then when you go to admin 1, it gives the individual states how many cases. So it is a very informative website, and you can update. It gives a real-time cases and mortality rate. So let's talk about science behind COVID-19. If you look at the disease spectrum, approximately 80% of the people were with mild symptoms. Approximately 15% were severe symptoms such as lung infiltration, low oxygen saturation level, and high respiratory rate, which is more than 300 per minute. 30 per minute, And the main thing is the COVID-19 infection, only 5% of the cases were reached critically ill status, such as organ failure or need mechanical ventilation. So those 5% are mostly the age of above 55 and or above 60. So it's our responsibility to protect our elder people. And although if like an age below 45, we get infected, we can recover easily from the virus, but not the people, those who are elderly people that over 65. You see the morphology, if you look at the right side, scanning electron microscope image released by National Institute of Health clearly shows the SARS-CoV-2 virus interact with human epithelial cells. That's the first, the primary cell that interact with virus, in a human cell that interact with virus. It is a beta coronavirus family. If you look at the structure, it has spike proteins and envelope proteins, nucleocapsid proteins, and membrane proteins. These are all the proteins that indirectly supports the entry of the virus and replication of the virus and viral structure. So SARS-CoV-2, the main thing is SARS-CoV-2 carries a positive RNA. So what is the difference of positive RNA and negative RNA? HIV carries negative RNA and this carries positive RNA. The critical thing is the positive RNA, which is ready to translate. That's a major disadvantage of this. Because of that, it's easily multiplied within our system. Previous outbreaks clearly shows that SARS-CoV-2 is a sequel of SARS and MERS. Bat is the most likely the natural host. SARS and SARS-CoV-2 interact ACE2 receptor, the human epithelial cells, the primary contact, receptor DPP4. Irrespective of that, all this leads to acute respiratory syndrome. And if you see the picture here, how the spike protein interact with ACE2. So here I gave an example of human epithelial cells that expressing ACE2 receptor, acetylcholinesterase 2 receptor, and how the interaction with the spike protein. Once the virus attached to the lung epithelial cells via ACE2 or TMPSS, or it is called transmembrane protease 2. So these are the two receptors on the cell surface that facilitate the virus to enter into our system. So once it entered, we call it as endosome. So this is called endosome. So once the endosome, it fused with the lysosome, and lysosome digests the material and release the viral genetic material into the cytoplasm. So once it enters into the cytoplasm, that takes our machinery to multiply and release different copies of viral protein as well as virus genetic material that go and translate using the ribosomal machinery, and that leads to more proteins and genetic material, and it enters with the help of Golgi system that assembles inside the cytoplasm and released and has so many viruses in our system and infect neighbor cells. And you look at the disease progress. Once the virus enters into a respiratory tract, it goes to alveolus. So it enters and it goes to deep down into the lower respiratory tract at the alveolus. Here you see what happens inside the alveolus. I just magnified to understanding what's going on inside the system. So once the virus enters inside, it directly attacks the epithelial cells. There are two types of epithelial cells. The first one is type 1, responsible for oxygen gas exchange, whereas type 2 epithelial cells is responsible for maintaining the tension in the alveolus. So if there is not maintaining the tension in the alveolus, then our lungs will collapse. So that for maintaining the surface tension in the alveolar, these cells release surfactant. So the primary contact of the virus is type 2 epithelial cells in the lung. And once it infected and start multiplying, the cells start releasing cytokines. And once it starts shedding cytokines, immediately our resident macrophages reacts to that and start releasing further cytokines such as interleukin 1 beta, IL-6, or TNF alpha. So these are the cytokines that further increase inflammation and vascular permeability. And besides, this infection leads to infiltration and fluid accumulation. That's why we call it as lung infiltration. Within 48 hours, that severely infected patients that alveolus filled with fluids, because these cytokines interact with the vascular layers that will make the junctions widen. Due to that, there are a lot of fluid escape and then get into the lung alveolar space. On the other hand, these cytokines enter into the systemic circulation. So there comes the complication actually. So once it's entered into the systemic circulation, that means all the cytokines are irritants, or not normally that irritate the vascular bed. So when the entire system is irritated, that leads to sepsis. That condition we call it as sepsis. In this case, we call it as viral sepsis. So now what is the sepsis in definition in Center for Disease and Control Prevention is giving? Sepsis is a resulting from bacterial, it's either a viral infection, can cause inflammation-driven coagulation disorders. I will talk about coagulation later on, but inflammation-driven coagulation disorder, that state is called disseminated intravascular coagulation or blood clot, or we call it as thrombosis. There are so many standards of care, antibiotic therapy or antiviral, as sepsis remains the commonest cause and death among the hospitalized patient. And if you have to believe this, on an average, 250 to 300 patients, those who hospitalized in the US, are dying because of sepsis. And globally, 30 to 50% of the people are dying because of sepsis. That is really striking, highest percentage, but that is the reality. And this is before COVID-19. I don't know what is the percentage now after this COVID incident. So before I talk about sepsis, so first I have to give a few slides, and I will show you how our clotting system works. This would help to understand the concept of blood clots in COVID-19 cases. Imagine that we collect blood drops from our finger to test blood sugar or a blood group. When we make a deep prick with a disposable blood lancet, that damages our blood vessel. I depicted here. So that damages our blood vessel. That's why we get a drop of blood on the surface. Normally, it should be stopped within 2 to 5 minutes. Depends on the length of the cut that we make. Okay, let's zoom in and see how it stops bleeding in a healthy individuals. When there is an injury, the nerve endings releases certain kind of contraction, and it's called myogenic contraction, nerve neurons. Besides, those damaged cells, the endothelial cells release a substance called nitric oxide, PGI2, and endothelin. If you remember, the nitric oxide is released inside the circulatory system. That means that is a vasorelaxant property. Whereas during an injury condition, when it releases subendothelially, that leads to vasoconstriction. So what happens when endothelial damage, immediately that sense there is a collagen layer bottom, and endothelial cells start releasing a factor that is called von Willebrand factor. So I made it as I spelled it there, von Willebrand factor. And once the von Willebrand factor makes a glue, immediately the platelets, our blood circulation is keep rotating, in every 15 minutes, the cells reach entire circulation. So immediately the platelet, which is passing through, immediately sense this, there is a von Willebrand factor, there is an injury, immediately it go and binds. So how it binds? That binds through a receptor called glycoprotein or GP1B. So this GP1B, von Willebrand factor interaction leads to activation of phospholipase A2 inside the platelets. That leads to conversion of phospholipase A2 into arachidonic acid by phospholipase. These phospholipids come from the surface of the platelet. The platelet surface is made up of phospholipids. So once the arachidonic acid is formed, that converted into thromboxane A2 in presence of cyclooxygenase. That's why we are using aspirin to cut down the platelet activation during a stroke for stroke patients. So now this process, we call it as this process is adhesion of platelets, adhesion and platelet activation. Now the platelet is activated, but this is not enough. This is just a monolayer. So it has to be sandwiched. So for that, these activated platelets. So these activated platelet substances. So it has alpha and delta granules. Let's say alpha granules has a serotonin, ADP, and calcium. So the calcium is very important for our system because during this clotting system, the cascade of coagulation factors being activated. I will show you what are the clotting factors on next slide. But those factors, it needs calcium to interact each other. And also it releases other clotting factor like factor 5 and fibrinogen. These are all important for the activation of coagulation. So because of that, there are a lot of the substances like thromboxane A2 or ADP releases into the system that leads to more platelet come and attach. So make a sandwich. And this process, we call it as aggregation. So the first process, we call it as activation, and the second is aggregation. It's aggregating on each other. So now this process is a primary hemostasis. So now what happens is a secondary hemostasis. Now there was an injury and all the factors comes on and platelets aggregated. But this platelet aggregation is not stable at all. And it has to be stabilized. So that's a place where all the cascades or clotting factors gets in. So when there are two pathways, let's call intrinsic pathway and extrinsic pathway. So extrinsic pathway is the immediate pathway within a second that will get activated when there is an injury. So what happens once this process, these cells release, damaged cells release a factor called tissue factor. So that's my research work, majorly working on how tissue factor influencing COVID-19 patients and how we could control the release of, control this activation of coagulation. So this tissue factor, what it does actually, it binds with factor 7. So it binds with factor 7, make a binary called tissue 7 here. So what happened, this complex activates factor 9 and as well as factor 10. So those factor 10 into 10 here, this is the active form. When I mention 10A, 7A, that means active form of the particular factor. So this complex activates this cymogen form of factor 10 into active form. And once the active thrombin is formed, that converts prothrombin to thrombin as a cofactors, calcium and factor 5. So the thrombin, it is well known, any infection, in clinically, it's well documented that thrombin generation was high rocketed inside the system. In COVID-19 also, it's documented that thrombin is really super high in those patients. So once thrombin is formed, that converts the fibrinogen. Remember the fibrinogen is an abundant protein in the circulatory system, and platelet also release fibrinogen that converts to fibrin monolayer and monomer and makes a small knot on top of the platelets to stabilize the platelets. But on the other hand, for the intrinsic pathway, so the platelet surface are phospholipids, right? So this activated platelet surface activates factor 12, and that activates factor 11, and that connects. So this pathway is called intrinsic pathway, and this pathway is called extrinsic pathway, and this pathway is called common pathway. So there are 3 pathways is going around. Okay, so now this monolayer, fibrin monolayer on top of platelets, it is not stable. It has to be further stabilized. So for that, a thrombin release tissue fibrin stabilizing factor or factor 13. It's a new factor. Is not much studied on the role of this factor. So what this factor does is like it just make layer. So this way, it completely stabilizes the particular injured site. And this entire process is happening within 30 seconds. So that's an amazing how our system works. So what's happening in the COVID-19 patients? So in COVID-19 patients, the same mechanism that happening in severely infected patients that leads to microthrombi, but it's not a particular area, it is all over the body, which leads to, that is the major reason for the mortality in ICU patients, those who admitted in the hospitals. The thrombus from all the joints and microvessels and kidney failure and lung microvessels. So once it blocked all the places, it goes to brain, it creates a stroke. And if it goes to heart, the heart muscle will, myocardial infarction will create. So that's a major problem. So most of the patients die during infection is due to activation of blood clots. So when it happens throughout the body, that's what we call it as sepsis, or disseminated intravascular coagulation, or thrombosis. Okay, so now on an average, every day, that everybody, even a normal individuals, making this kind of a small injuries, at least 1,000 to 1,500 approximately, I don't know the count, but we are making this kind, when you clap or when you hold firmly any material or when you touch the heat surface, since we know this, all the activated clotting factors to stop the bleeding at a particular area, but our system is circulatory system, it's keeps circulating. That means on an average, it takes about 45 seconds for blood to circulate from the heart and around the body and come back to the same place again. That makes seconds. Easily can go any part of the body and activate all the clotting factors, and we should all get disseminated intravascular coagulation or blood clot. But actually, it is not happening because there is a defense mechanism. So that's what I'm saying. So if there is this factor, since it's circulating, it goes all over, it's going to make a disseminated intravascular coagulation. But this complex is not happening because of certain defense mechanism. I'm not going to tell all the defense mechanism, but I would like to mention few important textbook mechanisms and also some additional work that I did. So that will clearly help you to understand how our system works very amazingly. So now imagine, now there is for us an injury, it's just already healed that injury part, but still these factors keep circulating in the system. It has to be shut down at some point, otherwise it's a danger for us. So how it shut down? When there is an active platelets, activated platelets comes to the normal vasculature. That means it's a normal vessel, there is no damage, it's a healthy vascular barriers. In that case, the endothelial cells sense and release a substance called nitric oxide, prostaglandin I2, and ADP dephosphatase. We know ADP is an aggregation. So a dephosphatase that just shut down the platelets to a normal. It won't activate platelets to the normal. So now we put down the platelets. So what next? Now there is an active thrombin, active factor 10A, active factor 9. So these factors, when endothelial cells sense these active factors, immediately the endothelial cells release a factor, it's called heparin. So I made it as a letter, heparin sulfate. And heparin sulfate bind to antithrombin, and this complex inactivates, break down this active form of thrombin factor 10A and 7A. So this mechanism only we developed heparin as an anticoagulant, and we are using all over the world. Even the COVID-19 recently FDA approved as an emergency drug for treatment to reduce blood clot. The third mechanism is now we shut down platelets, thrombin, factor 10A and 11, but now we have, 9, but now we have factor 5 and factor 8. So when those factors come to the normal endothelial layer, and then immediately the endothelium release a receptor called thrombomodulin. So this thrombomodulin binds to thrombin, and that activates protein C into activated protein C, and that inactivates factor 5 and factor 8. So now almost half of the factors are knocked out. But if you look at, there are fibrins, there must be some of the fibrins circulating. So how that is inactivated? So when there are fibrins circulating in the system, which is above the normal level, and endothelial cells sense that and can release a factor called TPA and called tissue plasminogen activator, which we are using it for our stroke patients, and uroplasminogen activator. These are the enzymes that converts plasminogen to plasmin inside the system. So plasmin is one of the plasminogen is an abundant protein in the circulatory system that converts to plasmin, that cuts the fibrins to fibrin degradable products and eliminates. So that's how the mechanism works, how it puts down the entire system. And there is another mechanism that I'm working on and published, like the complex tissue factor 7A, 10A complex. That's a central dogma of clotting cascade activation. So that was completely arrested by endogenous anticoagulants called TFPA, or tissue factor pathway inhibitors. So there are other mechanisms, alpha antithrombin and everything, but I'm not going to talk about that, but just for understanding, okay, these are all the mechanisms that keeps our system in a liquid state. There is no injury. That's what happened in COVID-19 patients. So there was a study recently published in Lancet. They measured D-dimer, that survival and non-survival ICU patients, and they measure the D-dimer. So what is D-dimer here? D-dimer is nothing but they're measuring fibrin degradable products. That means if there is a more fibrin degradable product, that means there is more activation of clotting inside the system. And you can clearly that correlate with D-dimer increases in the non-survival patients and compared to survivors. So whatever is a more than 1 microgram per ml is really bad, and it is a high risk of getting thrombosis or disseminated intravascular coagulation. So the same thing, that's what the pulmonary microthrombi. So the histology from infected patients and autopsy showed that pulmonary microthrombus, if you look at here, it's a very huge microthrombus, and also the alveolar damage they observed. And based on this study, D-dimer level crossed 1 microgram per ml, then the patient is under risk of thrombosis. And recent study demonstrates that vascular endothelial cells express high level of ACE2, and also it has infected by SARS-CoV-2. So the anticoagulant therapy should be initiated for severely infected patients. If otherwise, it's contraindicated. So some people are resistant to heparin, they create heparin-induced thrombocytopenia. So that has to be, certain tests have to be done before infusing or treating patients with anticoagulants. Let's move on to the treatment strategy. And this is more fun part, actually. There are so many, there is no treatment. First of all, I start with that. There is no treatment. And if anybody infected and a severe is, first thing they need respiratory support, that means ventilation, and they need circulatory support. And if they have some problem with the kidney cells, that's the next, after lung, the next is the kidney. Kidney failure is immediately will happen. And the other treatment, like convalescent plasma. So convalescent plasma in the sense like a patient infected and recovered from the disease. So they have already an immune system. They already have antibodies. So those antibodies we infuse to the patient, new people who infected just now, like we identified just positive, but they don't have much severe symptoms. We can use this antibody to neutralize and stimulate the system. The other way is a prophylaxis and blood purification and immunotherapy, and we can do corticosteroids and other therapy like antivirals to put down the virus load. So let's start with the vaccine first. And so this is my interesting area. So vaccine, before we talk about different type of vaccine and what's going on, I would like to give a vaccine basics. So vaccine, how we develop the vaccine is nothing but we are developing an immunity. So coronavirus, when it infected, we know with spike protein or M protein or ACE2 receptor and TMPR receptors, a co-receptor that phagocyte, release the material, translate, and viral assembly and release. So once it released in the system, from the cells, we have a lot of immune cells, like antigen presenting cells, like let's say dendrocytes or macrophages, that immediately phagocyte these cells, digest, and then take this antigen peptides. It's here, what is the antigen peptide in coronavirus is a spike proteins. So it brings the spike proteins on the surface and then allow T cells to interact. So once T cells exposed to, that cytotoxic T cells or B cells, and those B cells are producing antibody that neutralizes the virus. On the other hand, cytotoxic T cells directly kills the infected cells, and B cells, once it does, B cells once it finished the work, and what it does is just become a memory B cells, and whenever the virus comes next time, and that attacks, so then the person is already developed immunity. So there are several type of vaccines. So these are all the types of classical vaccines. This is a live attenuated vaccines, inactivated vaccines, that means kill the vaccine by chemicals or by heat, and subunit, like only pick a particular protein of that antigen part and then purify that antigen and then use that one, and toxides. And we know this, we used polio vaccines is one good example for live attenuated vaccines. And there are several vaccines like similar way we have right now, we are using it. But it's called next generation vaccine. So before I go to the next generation vaccines, I would like to give you some detailed information about how these vaccines are work. The first one is a weakened virus or inactive vaccine. That means a mutated version of the virus which cause no or less harmful effect. So we by the scientists pick those virus, culture and pick those virus, and then they infuse into the system. So what will happen if it is a coronavirus type and then it is a mutated form, it will get into the cells, multiply, but you won't get much symptoms, or you won't get much illness, and it develop your immune response. On the other hand, maybe it's totally different, but the genetic material is nothing. And what happens is directly goes in, and then it directly uptake by the antigen cells like dendritic cells or macrophages, and then exposed to the T cells and create the immune response. The next one is the vector-based one. So what here is only they take the sequence of the spike protein and then insert into the vector, and then put the vector into the system. So if you have a coronavirus as a medium vector, and then the coronavirus inside, if you put a vector, and then that will go into the cells and replicate, and then phagocytous by dendritic or antigen presenting cells, and then T cells and B cells and immune response. On the other hand, some totally a different virus, and that what will happen, that won't go, it's directly phagocytosis by the antigen presenting cells and create immune response. So the third one is a protein subunit, and here the protein subunit, the spike proteins or M proteins or the antigen actually that required for the immunity or creating a much infection in our system. So only pick those spike proteins as a protein from isolate from the virus and then inject. So what happened immediately, the virus will pick up those proteins and then create an immune response. And it is very, I should mention here the SARS virus, which is outbreak 2002, that protect monkey against the infection, but haven't been tested people. Think about vaccine, it's coming next year or next month. That is not possible actually. So next, a virus-like particle. So that means there's a, only the envelope, no genetic material, just an envelope of the virus. Then we'll put into the virus and automatically it won't go into the cells because nothing, no genetic material. It directly uptaken by the antigen presenting cells and signals to the T cells and B cells and create immune response. So these are all the types that is regularly that we are using and still under development, but there is a new next generation vaccines. So if you look at the next generation vaccine, that's called DNA vaccines and RNA vaccines. And DNA vaccines is nothing but the coronavirus spike protein in the DNA. It needs a special kind of an electroporation device, and this company, and I'll tell you the company. So this company also makes this device along with the vaccine parallelly, and we need this vaccine, we need this device to put in this viral DNA material into our cells to better increase the uptake of any CRISPR target into the cells. We need an electroporation or something like that. But we are doing it in a locally in human. And then what happens, it creates an mRNA selective to the spike protein, because we only put in a spike protein. So that spike protein, and it won't multiply to other cells because it is a local effect. But spike protein will release and create immune response. And that will create an antibody against or program our immune system. The second one is an RNA vaccine. So it's nothing but an mRNA vaccine. And mRNA vaccine is the same. The viral material is encapsulated by lipid and put it into the system. So what happens when you inject? The viral material is directly, because it's a positive charge RNA, it's directly multiply and give a protein, and that protein is uptake by antigen presenting cells, and that release immune. So there are two companies. That's the first company is called that creating DNA vaccine is Inavio, and they are in phase 2 and 3 successfully. And the next company is Moderna. They are working on RNA virus. These two DNA vaccines are next generation vaccines. There is no vaccine available in this type of this method, but they are very fast in bringing into the clinical trial. This is a phase 3. So they're going to start emerging like phase 2 and phase 3 now, and it is really interesting. And especially Moderna yesterday published in New England Journal of Medicine, they found like super immune response when patients exposed. Not only the young patients, it's also the people not healthy individuals, also the old people, the healthy old people also created the nice immune response. But I don't know what will happen in phase 3. It's most of the drugs we all know as a pharmacist, like almost 80% of the drugs fails in phase 3. So if you look at an array of vaccines, more or less closely 100 vaccines are under development for COVID-19, and let's see what will happen. Hope for best, at least out of 100, we will get at least one before 2025. And next, talk about the drug controversy. It is a good topic to discuss about drug controversy. It's called hydroxychloroquine, and you guys all heard about hydroxychloroquine, and you also bought a lot of doses from India. So this hydroxychloroquine is actually an anti-malarial agent that increases the pH of the food vacuoles of the parasites, and that's a mechanism how it killed the parasite. So if you look at the mechanism based inside the parasite vacuole, and it captures our hemoglobin and take the peptides from our hemoglobin, and because of digesting that, it gets some peptides and hemes, and it convert this heme with using its endogenous protease, convert as a hemozyme and keep it preserved. Why converting? Because heme is a toxic. When it accumulates in our system, it's a toxic. And that's the reason the parasite escaped, but he needs protein, it gets along with the protein, it also gets heme, and it converted into like a polymerized form. But what hydroxychloroquine directly goes and change the pH inside the vacuole. It is a hydroxychloroquine is an alkaline. It changes pH from the acidic, so that leads to neutralization of immobilize the reaction of polymerase function, so the heme will accumulate, and that's how the accumulated heme kills the parasite. So that's a mechanism how hydroxychloroquine works. And besides, there are a lot of studies. It's well known. It also used for rheumatoid arthritis because it has a capacity to block synthesis of IL-6, IL-1 beta, and TNF-alpha, and antigen presenting cells. So when antigen presenting cells, if you remember that how the vaccine works, I showed the antigen presenting cells pick up the spike proteins, and those proteins not only just exposing to the T cells, at the same time those cells also react and release cytokines, and those cytokines are inhibited by hydroxychloroquine. It is a different purpose. So when I talk about the controversy, the first controversy is increasing the first paper. In March, it's super hyped, And everybody started looking hydroxychloroquine is a drug that we could completely cure the disease or whatever. And but the Lancet paper released and it gained a lot of attention. The study was reported based on patients' data from 670 hospitals on 6 continents. So actually they didn't do any study. It is kind of an multinational registry analysis. So they collected information from a different part. The company who collected in based on Boston or New York area, I don't remember. So it's called as Versiti-Blood. So that company, actually it's a healthcare analytical company. So that company collect all the data and then compile and then as a registry analysis. But that was improper. And there are a lot of debates, and then suddenly the journal asked independent review, and then the company is not ready to cooperate. So that's why the paper retracted. So what this paper is says, when you take when you take hydroxychloroquine, treat the patient with COVID-19 patients with hydroxychloroquine, they create a ventricular arrhythmia. So what is a ventricular arrhythmia? It's an improper control of ventricular, it's called a ventricular tachycardia that leads to frequent pumping of heart that leads to platelet activation. So that's a major problem. They get a prothrombotic complication. So suddenly the FDA, I think in March and April, FDA approved as an emergency drug for treatment of COVID-19, this hydroxychloroquine. But after this paper, in June mid, FDA revoked that, okay, the hydroxychloroquine should not be used. But what happened next? This month, there is another paper from the US, a systematic study. They used hydroxychloroquine and hydroxychloroquine with azithromycin. So this combination came even in 2002 when SARS was outbreak. So this combination and also a control placebo group, and it clearly showed that a significant reduction in hospital mortality with hydroxychloroquine for treatment of COVID-19. So this drug has a certain benefit, but it depends on when we use it. Timing the drug is more important. I don't know what will do FDA now. Maybe they will come back and say, okay, we can use hydroxychloroquine further. I have no idea. So we have to wait and see. Next, we are going to talk about Remdesivir, because this is another drug approved by the FDA. And Gilead is the company that rapidly developed this. But actually, I would call it, this is a repurposing drug, because this drug, Remdesivir, is not for COVID-19. Actually, it's for Ebola virus. It is long back outbreak, and just now the Ebola outbreak, the drug is in the phase 3 trial. Think about COVID-19, it will take so long. So before I talk about how the Remdesivir works, and just recap how the virus replicates, that will give you some impression on how this drug is going to work. So virus or spike protein in the human, interact with epithelial cells, once enter the release phagocyte and release the genetic material into the cytoplasm. And then it takes the ribosomal machinery to multiply the viral protein or genetic material. And then it assembles with the help of Golgi and it releases. So that's a sequel of how this virus multiply in our epithelial cells or endothelial cells or different cells, whatever cells express ACE2. So here, the Remdesivir is a drug that was initially, as I mentioned, it's for the treatment of hemorrhagic fever that targets endothelial cells. So it is nothing but a nucleotide analog. It's an adenosine analog. So actually the metabolites are responsible for as a treatment. We can understand here what is going on with the Remdesivir. So we know always this nucleotide synthesis is happening when you're multiplying in, different nucleotides come and attach to that. And then suddenly when we have a Remdesivir, what happens, since it is an analog of adenosine, so instead of the adenosine, actual adenosine, this Remdesivir go and sit on there. So once it sits on there, then ribosome thinks that, okay, maybe it's something wrong. So immediately that stops multiplying. So it will get a defective virus that may not come out. Sometime it will create, sometime it not. The major thing is not effective in COVID-19, that how they climb. Actually, it is less than 10% compared to placebo control. You know, placebo mortality rate was around 20%, sorry, 30%, and this was like 22. So it is like less than 8%. And this is only FDA approved as an emergency drug. So there are high chance anytime this drug will be revoked from the market. So let's see what are the other considerable alternative treatments. So as you mentioned, as I mentioned, that IL-6 and interleukin-1, those are all the cytokines that secrete. So we can like block those cytokines by using antibodies. On the other hand, we can use chemostat that inhibits the core receptor TMPRSS2, or else Remdesivir that blocks the this viral replication. And when you go for Lopinavir, it's a protease inhibitor, or hydroxychloroquine that blocks the fusion between fusion of endosome into the lysosome, and also the release of the assembled virus. And we know that convalescent plasma, so as I mentioned, so as infected and recovered patients, we collect the plasma. Actually, it's a serum. I don't know why they call it as convalescent plasma. And serum has a lot of antibodies against that virus, and then that plasma will act on the host individual and then suppress the infection. So now we look at the clotting and coagulation factor related, the possible treatment strategies. So in a critically ill patients, if the D-dimer level is more than 2 microgram per ml, if it is more than 2 to 3 microgram, it's severely high, it's more than 10 or 12, they are high risk, we need high dose. But if they need low, like kind of 6 or 5, then they need low dose of anticoagulants. What are the anticoagulants? Is a prophylaxis or parental. So once they know this, the patient have in ICU, but he's not showing any symptom related to clotting, but the D-dimer is pretty high. And if it is high, what they will do, they do normally treat the patient with high molecular weight heparin. So what high molecular weight heparin do? It blocks factor 10 and thrombin. Now, if you remember the clotting cascade that the pathway explained, that's a mechanism. So when it blocked, automatically the further fibrin generation won't happen. And then low molecular weight, but the problem is that leads to bleeding. So that's how the low molecular weight heparin came, that only blocks factor 10, not thrombin. So this way it can reduce the bleeding complications. But if the patients are high risk, but they recovered from COVID-19, so the doctor normally prescribed here is with an oral anticoagulants like rivaroxaban. It's a direct factor 10 inhibitors, and also dabigatran, like direct thrombin inhibitors. So this is only described for the patients who discharge and for at least 2 to 4 weeks, so that they won't come up with kind of infection-derived hypercoagulation state. Come to clinical trials. So I'm not going to discuss much on clinical trials, but I would like to highlight how many trials are going on. So right now, 510 plus drug development programs is planning. So they're communicating with the FDA that they developed a certain stage of preclinical data. And around 230 applications or trials are reviewed by FDA as of yesterday. And 2 drugs are approved, actually 3, and hydroxychloroquine was revoked. So now it's only 2. The first one is Remdesivir, and then the second one is the heparin sodium for the reduce the clot. And there is no specific approved drug. So if you look at the what are all the trials is ongoing, antiviral drugs, like more than 20 drugs, antiviral drugs are going on in the clinical trial, and cell therapy, where it comes the Mesoblast, the company. So that company has the stem cell based therapy for lung inflammation and respiratory syndromes, and immunomodulator neutralizing antibodies like IL-8 and IL-6 antibody, TNF-alpha antibody, IL-1 beta antibody. Maybe it comes under vaccine and combination therapy. So one good example is hydroxychloroquine and azithromycin together. It's a combination still under clinical trial. So overall, that I hope my presentation increased your knowledge on the current status of COVID-19. Even if you cannot remember everything, no worries, but remember this slide. So this slide is the main slide of the topic, I would say, and never forget. So wear a mask. Recent study demonstrated that wearing face mask reduced 65 to 70% of the disease spreading rate. So it's a mandatory, you need to wear a mask and monitor your health irrespective of exposed. When you step out and any reason, when you go back, you have to be monitor your health at least for 14 days. For at least for 6 months, we have to have it's a regular habit. Definitely avoid mass gathering for another 6 months to a year. And the main thing, don't step out of your home without a mask for at least 6 months. If you want a good example, if you look at the US, they were like almost half the way flattening the curve, and then it's open up the country. They started going to beach and everything, and also this protest. Suddenly, it is totally upside down. So, and also now winter is coming. I don't know what's going to happen. So the same situation, the rainy season is coming in India, and it's just now started in India. It's going to be a hot spot. So try to avoid by just wear the mask. And one thing is, we need to improve. This virus is targeting our immunity. We are lucky that we are in India and we have rich in nature of spice and vegetables that boost our immunity. So this virus is already spread globally. So make use of it, of the spices and vegetables, and this virus already spread globally, so nobody will escape from this virus. It's bad to say, but that's the reality. Nobody will escape from this virus. So be prepared to face and start live with this virus. Thank you.
Thank you, sir. Now I request Dr. Vadivalan to coordinate the question and answer session.
Thank you, Dr. Praveen. Thank you, Dr. Saravanan Subramaniam, for your wonderful session with the blood clots and COVID-19. And in this session, you have given the brief introduction about the origin and the transmission of SARS-CoV-2 and what are the possible targets of SARS-CoV-2 by using the vaccines and the possible available drugs in the market. And you have explained clearly about the involvement of the blood clots and its role in COVID-19. Here are some few questions to be clarified by the participants. So the first question is, how blood clots happen in elastic vessels during brain aneurysms?
So in blood clots in brain aneurysm, it's kind of enlargement of the blood vessels. So when it's enlargement and dysfunction, that leads to kind of irritating, like damaging the endothelial layers. So aneurysm is, let's say in atherosclerosis condition, the aneurysm is a bulging of the blood vessel. So when the vessel, the direction changes, when it bulges, that leads to activation of endothelial cells. So when automatically if the endothelial cells is being activated, and that leads to aggregation of platelets, and especially if you ask brain, there's a very micro vessels inside. So when it's a very micro vessels, what happens? It easily block that site, and that's the problem why the aneurysm condition, the blood clots, is very dangerous. And I think we are using a TPA, tissue plasminogen activator, to treat because they are very high risk to get the stroke.
Thank you. I think the participant has cleared his doubt. And the second question, what is the... So the other question is, what is the difference between the vaccine and the existing drugs today which are under the clinical trials?
Can you repeat the question, please?
Yeah. What is the difference between the vaccine and the existing drugs which are in the clinical phase right now?
So it's very clear, drugs are nothing but it's targeting, it's a pharmacological targets. And moreover, we don't have much pharmacological targets as of now, but definitely, let's say remdesivir, that targets an inside our cytoplasm, where the ribosomal machinery, updation of viral genome. And a vaccine, it's an immunity. And moreover, this immunity, this virus is new and we don't have the immune against this virus. And that's why we are all getting this virus and suffering from this virus. And it's clearly that we need to expose. It's vaccine is nothing but we are exposing to the virus. It's nothing special. So that's a difference between virus and drugs. And moreover, the recent study also said that even though the immunity increases, that means the antibody protection by the B cells. And the recent study says that after 2 months, this antibody is shutting down. And that clearly tells that after 6 months, this antibody will be cleared our system. So it's a high chance that we might reinfect. This is another critical state that how we are going to dealing with. So that's the only option that we have to focus other than vaccine is small molecules and pharmacological targets.
Thank you. So the next question is, one of the researcher from CFD thermofluid dynamics, he was asking what is the advancement in hemodynamic applications? I think it is in the box, yeah.
Yeah, it is not relevant to my area, so I cannot. It's a good question, but I cannot answer because it's not relevant to me. I don't want to just give something random answer.
The next question is, how is protein intake play a part in COVID-19?
Can you repeat the question, please?
How is the protein intake play a part in COVID-19?
So the protein, the immune, especially we know very well this is the immune system is the major problem that we are facing. If you have a good immunity, we will get some sudden illness and then you recover after 14 days or 20 days. The problem is if you don't have proper immune system, that means if you're not diet, and that leads to there's no infection. It's a high chance that you will get more infection. So that's why the doctors are recommending that have a rich protein content in your food, so that you are immune. You can maintain your immune system.
Fine. I think there are again 2 or 3 more questions. To put a last question, one of the participants has asked some fluid aspects of blood clots during varicose veins. Can you address on that?
So the varicose vein is,
yeah, on varicose veins he was asking.
Yeah, so the varicose vein is a different pathology from the clotting that what we are discussing. And varicose vein is due to, sometimes if you stand so long and if the vessel, if you drink in an alcoholic patient, you could see clearly the varicose veins. So these are all the different pathology, but whatever the disease mechanism, ultimately it will end up with the damage of the vessel. So when you irritate your endothelium, if in a diabetes, you're irritating the endothelium by high sugar. When it's a lipid, you're irritating the endothelium with a high lipid content. The same thing, wherever you affect the structure or architecture of the blood vessels, immediately the vessels response that leads to a thrombosis. When varicose vein, what you see is nothing but a high complex structure of vessel bending and turning. And these are all the small places where easily the clot will clog in. And once it clogged in, and that's it, you will lose blood circulation to the downstream of the area. And that leads to loss of blood circulation and loss of oxygen supply. And that side, that leads to inflammation and maybe the damage of the particular tissue and below that region. Yeah.
Thank you, sir. Thank you, Dr. Vadivel. I request our beloved principal, Dr. S.P. Dhanbal, to give the closing remark.
Good morning, Mr. Dr. Saravanan Subramaniam.
Good morning, sir.
Yeah, this is Dhanbal heading this JSS College of Pharmacy, Ooty. This is my first time, I'm seeing you. And then, just now, your teacher, Dr. Justin, he told about.
He's my senior.
Oh, you're senior. Okay, yeah, you're senior to Dr. Justin, my colleague. So good to see you. And so very happy to have you here on board, to give a presentation on the topic blood clots and COVID-19 for the benefit of all our staff of the Department of Pharmacology and also all other departmental staff and also the postgraduate students, PG scholars, and also the students and the scholars and staff from outside other universities and colleges. And it's a good beginning, good presentation from you today on this auspicious day. Today is the Adi Amavasa day, very, very auspicious for the Indians. In fact, at 10 o'clock, and a puja in our ashramam. That's what I could not join for the starting of this session. And then, so thank you once again, for coming on board and then, engaging the students, and you made this week start in a very interesting week to start with. And so on behalf of our Chancellor, His Holiness Swamiji of Suturmat and officials of JSS Academy of Hajikis Research, Mysuru, and the staff and students of the Department of Pharmacology and also the staff and students of JSS College of Pharmacy, Ooty, we extend a hearty thanks to you all, you for coming forward on our request and giving your wonderful presentation on this current topic. We look forward to having your presence in campus. Mostly, if the things goes well, in 2021, during your next visit to India, please be part of our thing, and then come with family, and then be as our special guest to engage our students and also for the more interaction with us. So with this, I'd like to thank you once again for your engaging the thing and then accepting our invitation. Thank you so much. Have a good day. Yeah.
Thank you, sir.
Thank you.
Yeah. Dr. Saravanan, thank you once again. I once again would like to thank you on behalf of the department, especially on behalf of all my colleagues and coordinator Dr. Anand Vijay Kumar. And I think he was interacting with you continuously for a long period of time to organize this. So with this, with your permission, we may close the session. You would like to say anything in the closing remark?
Thank you very much for the opportunity that you gave me to give my work. Actually, I didn't give my scientific part because it's a restriction that I should not give any my data or something. So I just clearly blocked that part. And maybe the next time when I visit in campus, or probably I can give my scientific talk with COVID-19 and clot and all the inflammation related studies. And thank you very much for the opportunity, and thanks for everybody. And it's my pleasure that convey or disseminate my scientific content to the